The last sessions we have discussed on basics of ABG. Today I will be going to interpretation of ABG. The basics of interpretation, you divide one as the what is a gas exchange. That is the first thing that you will be looking for. In the gas exchange, one is oxygen and second is carbon dioxide. So you have to look at the oxygen, that is the PaO₂. It is fundamental because if there is oxygenation is not there, whatever be the value, the patient cannot survive. That is the importance of looking at the PaO₂. Carbon dioxide is by the looking at the PaCO₂. Carbon dioxide indicates ventilation. So basically the gas exchange you identify by the oxygenation and second is the ventilation. Hope this point is clear. Now we look into how will you assess the oxygenation. We have discussed this, so let's recap. One is by looking at the PaO₂, that is in the ABG, the saturation oxygen SaO₂, that is calculated from the ABG, and that is the SpO₂. This we have discussed in the previous sessions. We have also discussed the AA gradient, that is alveolar-arterial oxygen, and one more thing you should look for is the PaO₂ divided by FiO₂. What is this? That is a partial pressure of oxygen in the blood divided by the fraction of inspired oxygen. This is mainly for the identification of ARDS. Will come in the Berlin's criteria. We will come. We should also remember the alveolar gas equation for determining the PaO₂. Alveolar gas equation. And you should calculate the AA gradient. AA gradient stands for the alveolar-arterial oxygen concentration. What is the difference? What is the gradient? We'll go into a little more deep into the PaO₂. The PaO₂ depends on the fractional inspired oxygen, that is FiO₂, fraction of inspired oxygen. Second is the age of the patient. Third is the atmospheric pressure, whether the patient is at sea level or they can say the atmospheric pressure, barometric pressure. These are the three determinants of PaO₂. First we look at the relation between FiO₂ and PaO₂. Atmospheric pressure in the sea level, oxygen is 21%. Take it as 20, and the normal PaO₂ can be easily remembered as 100. So FiO₂ multiplied by 5 is the PaO₂. Hope this point is clear. FiO₂ multiplied by 5. So if the patient has is on 40% oxygen, the PaO₂ will be 40 into 5, 200 millimeters of mercury. Hope this point is clear to you. Again there should be a correction for the age. As age advances, PaO₂ comes down. In clinical practice, usually we take it as the relation between age and PaO₂. We can see simply 100 minus age divided by 3. So if the PaO₂ is determined by the FiO₂, age of the patient, and atmospheric pressure. Now think about what is hypoxemia. When the oxygen tension, that is arterial PaO₂, is decreased, we call it as hypoxemia. Normal usually 95 to 100 millimeters of mercury, that is the normal. We usually say mild hypoxemia when the oxygen is between 60 to 80, moderate 40 to 60, and severe less than 40 millimeters of mercury. So this is something you should remember. When the patient has got a severe hypoxemia, they are going to cardiac arrest, various arrhythmias, and brain death. In moderate, you will get tachycardia, hypertension, cold extremities, cyanosis, etc. So now we go into the calculation of AA gradient, which was with examples we have discussed during the last time. So simply by using the gas equation, we can identify the alveolar PaO₂, is written as capital letter PaO₂, minus PaO₂, that is arterial. It is normally 10 to 15. When you get hypoxemia, you have to calculate the AA gradient and identify whether the patient has got a normal AA gradient or increased AA gradient. So simplified gas equation, it will be 150 minus PaCO₂ divided by respiratory quotient. Again, we will discuss the details in the subsequent sessions. One more important calculation you should remember is the PF ratio. PF ratio stands for the PaO₂, partial pressure of oxygen in the artery, divided by FiO₂. This is mainly for calculating whether the patient has got a ARDS or not. When the PaO₂ divided by FiO₂ is less than 100, it is severe ARDS. Patient got severe ARDS as per the Berlin's criteria. Berlin criteria for ARDS. 100 to 200 is moderate, and 200 to 300 it is mild. So this is another thing. When there is a patient has got a hypoxemia, you have to calculate the PF ratio, should also be thought about. So in the gas, we have already mentioned that the ventilation has to be assessed. Ventilation assessment is by looking at the PaCO₂. When the carbon dioxide normally is 35 to 45 millimeters of mercury, when the carbon dioxide tension increases, that means there is hypoventilation. When the PaCO₂ is decreased, that is less than 35, it means patient is hyperventilating. So hypoventilation and hyperventilation can be identified by looking at the PaCO₂. When the carbon dioxide is more, it is what hypercapnia. Now we will go into an example, how to assess a patient when you get hypoxemia in the next session. Hope it was useful to you. Thank you.